Hi, this is data-Kanellopoulos from Athens, Greece, New York City, New York. I'm going to try, with hands-on on this patient, explain to you our latest topo-guided treatments on virgin eyes. This is a young myopic patient, nothing important on the pentacam, good thickness. This is a refraction, -4, very little astigmatism, minus 0.25 as you can see here, also on wavefront. And this is the topography that you can see that reveals some angle kappa, OCT to get a good view of the epithelial maps, Procyon, pupillometry, and then confirming the topographic astigmatism with the lens star. Both eyes measured here. I'll try today and explain to you our protocol in treating myopes with the topography guided platform by Wavelight Alcon. It's called Contura these days with a new launch. And we have a typical myope here, a 38-year-old male. And these are the refractions. We try first an auto refraction, what the patient is wearing. The patient is wearing -375 and -4. The manifest refraction, the dry refraction, -4.5, -4.5. Please note, nowhere here is the patient choosing astigmatism. The cycloplegic refraction with 1 drop of tropicamide, -425, -0.25 astigmatism. -4.5, 0.25 astigmatism on the left as well. The auto refraction post the dilation and partial cycloplegia, which is the same, and the wavefront measurements, which do show confirm the previous refractions, -432, -028, and 174, and -440, -043 at 12. Of course, routinely we look at the pentacam maps, which show almost 0.8 Doppler's of astigmatism with the rule, and this is a normal cornea, good thickness, minimal thickness 550, and the placido-disc topography, which, by the way, looking at the rings and the pupil, we can see that although this patient is a myope, has slight angle kappa and significant irregular astigmatism. This is not an extremely regular astigmatism, although we cannot claim this is irregular. So we draw these data into the laser with a WaveNet, and we place our initial refraction, which is our clinical refraction, -425, -025 at 140 degrees. But the pearl here is that the topographer, of course, the topographer cannot sense the spherical equivalent very well, measures and suggests we treat 1 diopter of astigmatism at 12 degrees. So this creates a little bit of a leap of faith to go with the topographer. So we will go in a case like this and look at the numbers with refraction set to 0. So I will manually go to 0 here, and of course we've asked the Wavelight people to possibly give us this image here as a standard default image on any topography guided treatment we will do, because it helps us very much. It gives us this attempt by the topolizer to normalize the regular astigmatism that we're seeing here and adjust for angle kappa. And of course, this treatment looks like a hyperopic treatment, so it will induce a little bit of myopia. So we will do a little bit of neutralization here. I'll add a 0.25 diopter myopia and see that now this ablation is more uniform, and thus ascertain that the topography guided normalization will create 0.25 Doppler's of myopia. So we'll hold that in mind. So now we will jump to correct the astigmatism that the topographer suggests. So I'll add to the 0.25 we had as a refraction arbitrarily half a Doppler more astigmatism. So I'll go to -0.75 of astigmatism, and I will respect the topographer's axis. So I will jump from 140 and go to 12 degrees. And this is a huge leap of faith. And I understand many clinicians will have a difficult time doing this, but our clinical results promise that this will give actually better vision to the patient. So now, we've added half a Doppler of astigmatism from our refraction, so we'll plan on subtracting 0.25 of myopia from the total sphere. And the total sphere was 425 plus 0.25 for the topography neutralization. That's minus 4.5. And we're going to subtract 0.25 because we increased the astigmatism. So we're going to end up again with 425, but you can understand that this is a heavily adjusted power. And overall, it seems that we're correcting a spherical equivalent of larger than the actual patient refracted, but it also includes the topography adjustment for the topography normalization. So this is the final treatment. Please note here that in reference to the pupil, the ablation is slightly decentered because this addresses the angle kappa for that patient. And we will treat this topography guided and also topography determined amount of cylinder and axis. And why does this happen? Our thinking and our suggestion is that these younger patients have a accommodative element in their overall refraction, which the wavefront cannot pick up, that balances out some of the refractive cornea astigmatism that the patient has. And we know by experience that if we treat just the refraction that the patient selected, sooner or later this patient will, quote unquote, have some regression and some astigmatism, which is nothing else than the astigmatism that we would not treat if we were not doing this topo guided. Our results have jumped from the 2020, 2015 level, uncorrected, to almost in every case 2010. Very impressive visual acuities, far superior to anything else that we've seen clinically through the last 20 years that we've performed LASIK. And I encourage you to at least, if not try this clinically, to follow this thought process through and familiarize yourself with what we use today in our clinical practice. And I thank you very much for your attention.
So in reviewing, you can see here the treatment if we were going to use our clinical refraction confirmed by wavefront. You see the topography guided device will adjust for angle kappa, but its suggested treatment suggests more astigmatism. This is with zero refraction. You can see the normalization and the adjustment of asphericity performing the device, and we decided that this is worth 0.25 of extra myopia to be corrected. And although these other numbers of clinical refraction before and after dilation, wavefront, and autorefraction before and after dilation, this is our final treatment to be performed, which includes more astigmatism according to the topographic data, angle kappa, and thus the adjustment of our correction. This is Dr. Kanellopoulos signing out.